Okay, now it's my pleasure to introduce our next speaker, who's going to talk on updates on therapies for hairy cell leukemia, and this will be by Dr. Robert Kreitman, who's chief of the Clinical Immunology Section in NCI's Laboratory of Molecular Biology. Dr. Kreitman earned his BS degree at Kent State University and his MD at Ohio State University. Yeah. He participated in a residency program in internal medicine at Duke, and he then came to the NIH, where he's been since 2000 in the Cancer Institute. The primary focus of his research has been on the therapy of hematological malignancies using recombinant toxins in the study of the interaction of toxins with the patient's malignant and normal tissues. And a second and partially overlapping area of focus includes the development of new therapeutic paradigms for hairy cell leukemia, both early and multiply relapsed forms of the disease, studies that he's done in partnership with, I believe, Ira Paston. His memberships include the American College of Physicians, the Association for Cancer Research, and the American Society for Clinical Oncology. So please welcome Dr. Kreitman back. Thank you.
Okay, so we're going to do a quick 25-minute update of therapies for hairy cell leukemia. And our objectives are to review the standard therapies, to discuss the current use of recombinant immunotoxins that we developed here at NIH, and to talk about some new trials of other agents for hairy cell. And I need to disclose that we're going to talk about the unapproved use of the immunotoxins and also rituximab and bendamustine. And I'm told that since the government owns our patents, I don't have to talk about that. And so leukemic reticuloendotheliosis, later called hairy cell leukemia, was first described by Bertha Bronkley, who I actually trained with at Ohio State University, but she described it in 1958. And it's a constellation of pancytopenia, splenomegaly, histiocytes in the blood and bone marrow with irregular cytoplasmic outline. And these were shown to be cytoplasmic projections, not really hairs, obviously. And there's a fried egg appearance in the bone marrow due to abundant cytoplasm. These are B cells, and they are strong for B cell markers, and they also express CD103, CD11C, and CD25. It comprises 2% of all leukemias, and about 900 cases per year, but the prevalence of this disease is probably about 15 to 20-fold higher, and we'll see why in a few minutes. There's also a poor prognosis variant called HCLV, comprising about 10 to 20% of the patients that have more severe spleen enlargement, more frequent lymph nodes, less cytopenias, higher lymphocytosis. They have absence of CD25, and they can be absent for CD103. And their response, most importantly, to purine analogs is very poor. So the World Health Organization currently lists these two diseases separately. However, Dr. Aron's in my lab has recently reported the presence of a poor prognosis variant called VH434, named for the immunoglobulin rearrangement expressed by the hairy cells, and that also has poor prognosis. It has features of both classic, shown in red, and variant, shown in green. It expresses an unmutated immunoglobulin rearrangement in 16 out of the 17, or 94% of cases, and it presents with lymphocytosis like the variants and cytopenias like the classic. So it sort of has the worst of both worlds. And it has poor response to initial Cladribine. Median progression-free survival after Cladribine is 5 versus 22 months, and the overall survival after diagnosis is 9 versus more than 26 years. So I want to back up and talk about the historical treatments for hairy cell and work forward. So steroids, single and multi-agent chemotherapy did little to improve the natural history, which gives about a median 4-year survival in untreated patients. And splenectomy perhaps adds a couple years to that. But alpha interferon, first described in the New England Journal in 1984, was the first systemic therapy of value in hairy cell, with complete remissions in a small percentage of patients, partial responses in about half, but these responses are not durable and go away after the drug is stopped. However, deoxycoframicin, also called Pennastatin, published in Blood in 86 and New England Journal in 87, was a major advance systemically, and this is one of the two purine analogs with high complete remission rates in the vast majority of patients, and even at 8 years, most of the patients are still in complete remission. And in this randomized trial done between Pennastatin and interferon, and this is the first and only randomized trial done in the United States comparing agents in this disease, there's a huge difference in complete remission rate with Pennastatin far better than interferon, and you can see a major difference in relapse-free survival as well. However, because of a high complete remission rate in patients crossing over to Pennastatin from interferon after interferon fails, we see no difference in survival in this trial. But Pennastatin is not the preferred drug in hairy cell leukemia. It's actually Cladribine, the other purine analog. And these two purine analogs work by similar but not identical mechanisms. So Pennastatin is a transition state analog between adenosine and inosine. So it's a potent inhibitor of adenosine deaminase. And Cladribine, as it's phosphorylated to 2-chloro-DATP, inhibits ribonucleotide diphosphate reductase and DNA polymerase alpha. And because of enzyme peculiarities in hairy cells compared to normal cells, these agents are markedly selective for hairy cells. Now, Cladribine was first published in the New England Journal in 1990 to give high complete remission rates and durability of response similar to what was seen with Pennastatin, but it's the preferred drug because it's effective after just a single 5 to 7 day course of treatment. However, there's no evidence that Cladribine can eradicate hairy cell. Even after 15 years of follow-up, the relapse rates are fairly constant. So, these patients accumulate over the years being resistant to purine analogs and other chemotherapies. So we treated these patients with our anti-CD22 recombinant immunotoxin BL22 and published in the New England Journal in 2001, also a high complete remission rate, but in this poor prognosis group. And before talking more about our immunotoxins, I want to mention that rituximab is also effective in this disease, and as published in Blood in 2003, in this single institution trial, 13% of patients had complete remissions. However, 8 to 12 doses of rituximab may be better than the 4 that was used here. And more importantly, rituximab combined with purine analogs may offer very high complete remission rates. And this caused us to wonder whether if you added rituximab to Cladribine up front at the early part of the disease, could you eliminate those few malignant cells that escape treatment with CDA and Cladribine and cured the disease? So we initiated a randomized clinical trial here at NIH, and this randomizes patients between initial rituximab, as shown by 8 weekly doses in orange, and versus delayed. And the Cladribine is shown in green. And we're treating patients on this trial who've had 1 or 0 prior courses of Cladribine. And our objective are to see if rituximab can increase the complete remission rate at 6 months. That's without minimal residual disease. It's a higher level of complete remission because they have to be negative by flow cytometry and immunochemistry, and also PCR. And we also want to see if the blood MRD-free survival is longer after simultaneous compared to delayed rituximab. And there's reasons to speculate that possibly delayed rituximab might give a better long-term outcome. And I'm not going to talk further about this except to show that we've enrolled 17 patients so far in 9 months. And of the 13 evaluable patients, our overall response rate is 100%, 85% complete remission rate, and 63% of the patients are MRD-free after rituximab and 0% without rituximab. However, the results at 1 month may not predict results at 6 months, and most importantly, follow-up well past 6 months will be needed to determine the long-term benefit of adding rituximab and whether this would replace Cladribine alone as a standard treatment for first line and second line in this disease. And so I'm going to leave monoclonal antibodies for a little bit. As you know, these kill cells by immune approaches and by apoptosis, and talk about immunotoxins, which kill cells directly by inhibition of protein synthesis and induction of apoptosis. And we use a special case of immunotoxins called recombinant immunotoxins, where we're just using the variable domains of the monoclonal antibody. In this case, I show the anti-TAC monoclonal antibody developed by Dr. Waldman to the IL-2 receptor alpha or CD25 fragment. The variable domains are joined by a linker and connected to the truncated form of Pseudomonas toxin that does not contain the binding domain that would otherwise bind to normal cells. And this molecule, LMB2, kills cells by binding to CD25 on the cell surface, going inside through a coated pit, unfolding at low pH, undergoing proteolytic processing, and then hitching a ride on a reverse secretory pathway called the KDL receptor to get it from the transreticular Golgi to the endoplasmic reticulum, where it can translocate to the endoplasmic, to the ER, to the cytosol. And once there, one molecule we believe is enough to ADP ribosylate elongation factor 2 and cause cell death. So this is a typical response that we would see in hairy cell leukemia with immunotoxin. This patient had a malignant count of about 500 cells per microliter in green prior to treatment, and this reduces more than 90% by day 3. This is the effect of the first dose, and more than 99% at 1 week. This patient got 2 cycles, as shown here by these inverted triangles, and the normal counts show a absolute granulocyte count of about 300, improving to over 4,000, and a platelet count of about 40, improving to over 200. The hemoglobin was supported by red cell transfusions prior to treatment. This patient has not required any red cell transfusions since 1998 when we treated him. However, he did require he did require more treatment with BL22 after relapsing from LMB2. And I want to shift and talk about BL22. As you can see, similar structure as LMB2, except there's a disulfide bond that is made possible by cysteine mutations in the framework regions that hold the FV together. And it targets CD22, so CD25 is expressed by 80% of hairy cells versus 100% of hairy cells expressing CD22. So CD22 immunotoxins would be our preferred agent for targeting hairy cells rather than CD25. And this summarizes our phase 1 and 2 experience with BL22. We saw 19 complete remissions, 6 partial responses for an overall response rate of 81%. And 13% of our hairy cell patients had a completely reversible hemolytic uremic syndrome during retreatment. So HUS is a clotting disorder in the kidneys that leads to anemia, thrombocytopenia, and decreased kidney function. But fortunately, this resolves within a week or two of treatment in all of our hairy cell patients. But we wanted to avoid this in phase 2, so we had selective retreatment. And we found that with just one cycle of BL22, we could induce complete remission in a quarter of the patients. And in those patients that we had to retreat, 56%, only those patients who did not have at least a hematologic remission defined by improvement to these parameters of normal cells, we were able to improve our overall response to a complete remission of 47%, overall response rate of 72%. So in comparing the phase 1 and 2 experience with this lower average cycles per patient, we saw a slightly lower CR and overall response rate, but the dose-limiting toxicity from HUS fell by more than half, and the immunogenicity rate fell by less than a third. So BL22 response, we found, was dependent on spleen status in that patients with splenomegaly, but spleens less than 200 millimeters, had a much higher complete remission and overall response rate compared to patients with larger spleens or post-splenectomy. So we believe that a large spleen may inhibit BL22 tumor penetration, and that splenectomy, on the other hand, may increase nodal and marrow infiltration of these cells and also causing a tumor penetration problem. On the other hand, it could just be that a large or absent spleen is associated with just more advanced disease. Either way, we believe that BL22 should be considered earlier in the experimental paradigm for treating this disease. And we'd like to mention that we have seen good responses even in patients with massive splenomegaly. This is a patient with a 250 millimeter spleen who after 6 cycles had complete remission, and to this day, 5 years later, remains in complete remission. So this shows our long-term outcome in all of our patients with BL22. We have not reached the median disease-free survival on phase 2 after a median follow-up of nearly 4 years. The median disease-free survival on phase 1 is about 3 years. And as shown in these vertical bars, patients still in complete remission, some of them still have no evidence of minimal residual disease by any test that we can look at. And so we'd like to know, in some of these patients, have we eradicated the disease? So to do this, we needed a more sensitive test than what's available. And this is the available PCR test, where you just use consensus primers that would bind to the expressed immunoglobulin rearrangement, which is specific in each patient with hairy cell, and in all of the and monoclonal for all of the hairy cells in that particular patient. So you would tend to see a ladder and no monoclonal peak if you had a large number of normal B cells. And so you can get better sensitivity with flow cytometry, and this is reported in collaboration with Mary Alice's group, than with PCR. But Dr. Aron's in my lab was able to clone and sequence these immunoglobulin rearrangements, design clonogenic or sequence-specific primers and a probe, and then do a real-time quantitative PCR using these sequence-specific agents. And we can get a sensitivity of 1 hairy cell out of 1 million normal cells. And this shows how you might use this technology. So this is a patient who got 7 cycles of BL22, as shown by these blue triangles. And this patient had disease in the bone marrow, shown by the D, prior to treatment, and had a complete remission, in other words, negative bone marrow after 1 cycle, but the flow cytometry shown in green was still positive. And it became negative after the 2nd cycle. But the RQ-PCR results stayed positive and normalized only after 7 cycles. And this patient continues more than 5 years later with no evidence of minimal residual disease. This patient, on the other hand, required 2 cycles for resolution of disease in the bone marrow and flow cytometry, but never resolved the RQ-PCR result, and he later became MRD positive, but still continues in a technical complete remission. So we conclude that RQ-PCR is the most sensitive detection method for MRD in hairy cell and may be useful in the future to gauge the number of cycles to treat with in order to possibly eradicate the disease. This is something you can't do with purine analogs because purine analogs, just one course is enough to deplete the CD4 T cell population for a median of 4 years. And we looked at the CD4 counts in our patients as well as T cell repertoire and CD8 counts. We found improvements rather than decreases with BL22 treatment. And this was not too surprising because these cells are, after all, CD22 negative. But what about normal B cells? So we found using PCR of the CDR3 domains and CDR3 spectrotyping by gel electrophoresis, also studies done by Dr. Rones in my lab, improvements in this B cell repertoire after 7 to 10 cycles of BL22. So we believe that we don't see normal B cell depletion as you would see with rituximab, which depletes B cells for many months after the last dose, possibly due to the short half-life of BL22. And so we conclude that since BL22 does not cause cumulative B or T cell depletion, it might be useful in multiple cycles to eradicate the disease in some patients. So to better target chronic lymphocytic leukemia, which doesn't have as good results as hairy cell, we, in collaboration with IRA, have tested a new molecule, HA22, that has mutations made in IRA's lab within the CDR3 domain of the heavy chain. This results in a 15-fold improvement in binding affinity, which translates in these matched patient samples tested by Ingram Margulies in my lab with a median 8-fold improvement. And this agent has been tested at the NIH and in multi-center centers in CLL, hairy cell, and non-Hodgkin's lymphoma in distinct separate trials. And so far, the hairy cell trial is furthest along, and we have a complete remission rate of 43%, overall response rate of 79 patients in all 28 patients. And in those patients who got more than the lowest dose level 5, we have a complete remission of rate of 48%. And we also have not seen dose-limiting hemolytic uremic syndrome, only 2 cases of grade 2, much milder form of HUS. I want to talk briefly about bendamustine because it has features of purine analog, as shown here in orange, but also in blue of alkylating agents, shown by the nitrogen mustard group. And although bendamustine has not been published to be effective in hairy cell, we do have data. There's a patient who was severely pretreated and very immunosuppressed with platelet transfusion dependence as well as red cell transfusion dependence, neutropenic, and a high malignant count in the blood, 800 cells per microliter, who responded well to bendamustine alone, and after multiple cycles is now free of transfusions of platelets and red cells. So to see if bendamustine would have a role in treating hairy cell leukemia, and I also mentioned that that severe adenopathy that it can accompany patients without a spleen also resolved well with bendamustine. So we started a randomized clinical trial of bendamustine and rituximab versus Pennastatin and rituximab in patients with multiply relapsed hairy cell, and for those patients with relapse, progression, or no response, they can cross over to one group or the other. So this is just summarize the trials that we have that are open for hairy cell leukemia in the country and in the world. that are specific for hairy cell. These are our immunotoxin trials, the bendamustine trial that I just mentioned, and then for early hairy cell, the cladribine rituximab trial. All these 5 are the only ones registered in the United States. They're all being done here at the NIH. And this is the only trial I'm aware of, a randomized trial, multi-center in Italy with 1 center in Switzerland, comparing IV and subcutaneous cladribine. So in summary, hairy cell is a highly responsive to, but not cured by purine analogs, pennastatin and cladribine. The variant and the VH434 variant respond poorly. LMB2 targeting CD25 is active in hairy cell, but only if they're positive for CD25. But BL22 targeting CD22 in hairy cell achieves high complete remission rates with 13%, fortunately reversible HUS. BL22, or HA22, the high affinity BL22 mutant, achieves similar complete remission rates at the upper dose levels without serious toxicity so far. And although the number of cycles are limited by protocol design, it may be possible to safely deliver enough cycles of immunotoxin as well as other forms of immunotherapy like rituximab and other antibodies to eradicate hairy cell in some patients. And I want to recognize my collaborators and colleagues, particularly Ira Paston and his section of the Laboratory of Molecular Biology. I want to recognize my clinical and research sections of my section of the lab, and also the pathology, hematology, medicine, pediatric branches, metabolism branch, the MARC facility that produced BL22 and LMB2, MedImmune that produced HA22, the pharmacy, and most importantly, the fellows and our nurses. Thank you very much.
That's great. Why don't all the patients go into remission?
Okay, so I mentioned immunogenicity. That's a big problem. Immunogenicity is when patients make antibodies to the toxin. And some of them actually may make some antibodies to the idiotype of the antibody. And so we find this a lot less often in hematologic malignancies than solid tumors, where you might get 90% of the patients making antibodies after 1 cycle. In hairy cell, maybe 1/3 of the patients will make antibodies after a single or 2 cycles. And so we're developing ways, number 1, to humanize the toxin, but also to immunosuppress patients a little bit more to get them to the level of a CLL patient where they would not likely make antibodies. But for right now, this is what's detracting from the complete remission rate that we have, I think most importantly. There is a small percentage of patients, maybe 5 to 10%, that have a poor response to these immunotoxins. We don't understand why. But it's not due to lack of CD22. That's high in all patients with hairy cell.
That's great. Other questions? Well, it's terrific to see a new approach to a bad disease give good results. Thank you.